Most any one of our videos was ever looked at was 14 views. That was 2 years ago. Lately, it averages 3. One of those is probably mine.
Well, you always look at it.
I look at
I just
look at it to make sure it's loaded right.
How many times do you look at it, Bill?
I look at it only once.
No, we're inviting Steve and Tyler next month, so jack it up a little bit.
I looked at one once.
All right, so approval of the minutes from March 17th. St. Patrick's Day, remember it well. I think we did have corned beef and cabbage.
My name didn't make it up. I was here because I had farmers.
So Phil, what
Yes,
Do you have someone who's omitted from the attendance?
Sue Franco, maybe I didn't sign in or something. I don't know.
You probably didn't sign in on the
Probably.
REMAC.
Okay,
Sorry,
sorry.
we'll make note. You're present.
okay, any other additions, corrections, deletions?
I'll turn up my hearing aid so I don't mess up.
Got the hearing aids on? Okay, good.
Motion to approve the minutes.
Don't laugh. Don't laugh.
Okay, all those in favor? Good. Thank you. New business, Sydney Center,
Sydney
new
Center
agency
is
medical director.
seeking approval for a new agency medical director. So I'll have the application here. Just a moment. Carlton Rule, R-U-L-E. Dr. Carlton Rule.
Okay. He's agreed to sign up for that.
He signed off on the role and responsibilities.
Dr. Rule's a family physician. He's actually the CEO for PRH Hospital, which is in Sydney. This would be a good guy to have on your side. Anybody opposed to Dr. Rule being medical director for Sydney Center? Good. Dr. Rule. You, Dr. Rule.
Masonville Fire District Ambulance is seeking approval for BLS Narcan use. Gus, I gave you that wad of paperwork from the agencies that are seeking approvals,
Okay.
and everything is in order.
All right. Narcan. Anybody opposed to more Narcan? Okay, hearing no objections, we'll approve that. Bovina, same thing.
Right, Bovina and Garrettsville both. Bovina, Garrettsville, and the town of Hancock, which is an ALS agency, they're seeking approval for BLS Narcan use.
Okay.
All their paperwork is in order.
And Dr. Markowitz signed off on Masonville.
I recall saying the name.
All right. Any opposed to those deployments of BLS Narcan? Okay. And Town of Hancock, also signing up for Narcan.
Right, you have all that paperwork there, Gus.
Dr. Berg is their medical director. All right, any oppositions to that particular deployment? Okay. Northampton.
Town of Northampton Ambulance seeking approval for BLS CPAP use. You have that paperwork there, it's all in order, signed off on by their medical director, Dr. Glenn.
Right. Anybody on the REMAC want to see the paperwork for BLS? Dave, are you still intimately involved in CPAP?
All my squads are being trained up to
So
speed.
it's moved out of demonstration
Right.
project, right? Okay. All right. So Northampton CPAP for BLS. Any objections to that? Okay. Let's skip down to Tego. Oh, that's just an informational thing.
I have there's a slight addition. There's always a slight addition after I do the agenda. Invariably, somebody will call up with a request for another agenda item. The Hancock Fire Department is seeking approval for BLS first responder status. This is not, of course, the same as the ambulance service. This is the fire department seeking BLSFR, and their paperwork is definitely in order. I gave you a copy of it there, and I guess we can give that copy to Joe afterward. definitely in order. Matter of fact, they gave us several more copies of some of the documents that we need to have, but that's all right. Rather a couple of extra than a couple too few.
Does the fire department run the ambulance service as well, or it looks like the town runs the ambulance service?
We're in the same firehouse, but it's two separate paperwork
Okay.
wise. So if we're out on a call going up to Binghamton, they get on the way back, they can first respond until the ambulance, and we're going to be the transporting agency as well.
Okay, so you support their
Yes.
application? First responder. All right, anybody opposed to Hancock doing that? Okay. And we can pass this to Joe. All right, informational on Otigo BLS CPAP.
Joe?
What is the information on Otigo BLS?
I have it right here, I'll read it off for you.
While we're doing that, anybody have any comments about opioid and EMS? The interface thereof? Okay. Any dramatic incidents or, reversals that have resulted in RMAs or other things like that?
We have, the Gloversville Fire Department has a written report here of successful use of intranasal Narcan. Gloversville Fire Department is a BLSFR agency, and they have a use here on the 4th of May. If you're interested, you want to press this down to go. If you're interested, that's their report. They successfully, they found an overdose, unconscious, and in grave respiratory distress on a parking lot. Needles alongside of them in broad daylight in the city of Gloversville, and they were first on the scene and immediately introduced intranasal Narcan, and with great success, thankfully. And the PLS CPAP use in Otigo, this was on the 2nd of April. It was a 56-year-old female with a history of asthma and COPD, and it was a very successful use. I'll pass this on down to Dr. Leinhardt.
So these are like positive reports of
These are very
Narcan
positive
and
reports, right.
CPAP.
Right.
We're not killing anybody with CPAP, right?
No, I'll have some interesting statistics for you shortly on CPAP and other interventions in the region.
We had a sign off after use of Narcan IV a couple weeks ago.
We just did one yesterday. They actually beat us out of the hospital. We transported him. He signed out AMA. That was actually, troopers gave nasal Narcan in the McDonald's bathroom. Brought him back and got him there, and he didn't want to go to Fox, so he signed out and left before he even got out of there. We passed him on the road walking back.
We had the same thing happen last month down in St. Mary's. Before I could restock my IV stuff, he was walking
Yep.
out and said,
Yep.
"Thanks for saving my life."
Yeah.
The only
See you in a few
problem,
hours.
the only problem with doing that is that they don't get the teaching and the tie-in to recovery and things like that. And they do leave all the time. At Cobleskill, we had one get out of the ambulance and wave goodbye and walk away.
This one never even made it. The one a couple weeks ago never even made it to the hospital. It was just
And chasing with the papers to sign refusal.
I guess that brings up a good question. What do you do with, because clearly they could still relapse
He
with an
left
Narcan
without
right
being seen.
Yeah.
I mean, the studies show with straight heroin, they're fine. You give them Narcan and they're fine. But with some of the newer mixes and certainly with fentanyl and things like that, they're going to go down again. So follow them. After an hour,
Slow.
after an hour,
Keep that IV there so it's easier to next time.
Deb, I remember years ago a little line on the old emergency show with Johnny and Roy about somebody who didn't want any help, and the chief is saying, "Remember, conscious, they're not your patient; unconscious, they are."
just wait. But seriously, the recovery piece is important, and as more and more Narcan gets out into the community, and you can walk into CVS and get Narcan without a prescription. You can order it on Amazon, but that misses the
Is that
recovery
true now,
piece.
then? Those, what you just said?
Yes. You can, you missed
Over the counter.
probably the most important part, is the recovery. So talking to those patients, you know, who want to AMA, you know, you can encourage them to come to the hospital so that we can help them with their recovery.
Don't the manufacturers put it in the labeling for the drug?
Should, right?
This may reverse your immediate problem.
Yeah,
However,
I don't know, I mean, the inside the Narcan package is a, you know, product information sheet, who reads it?
but it doesn't say anything about, 1-800.
I don't know, maybe it does. I don't know.
$15.
That's an opportunity. Yeah, I know, a lot of them don't want to defy death.
Yeah.
Some of them are very well educated on it already and still don't.
They, we had a meeting at Cobleskill Hospital yesterday to talk about dispensing Narcan from the emergency department as a part of an entire community countywide plan to not only, you know, have people reversed, but also draw them into a recovery program, and using the police substance abuse angels program and such that I know is present in a number of counties. And we were informed that people in the community, users, substance abusers, use Narcan like a designated driver kind of thing. You're the designated Narcan holder. And so they all party, but one person agrees to not, and they're the Narcan holders.
Safety net is in place.
They all decide to party.
But the Narcan kits are doses.
Sorry, can I have 6 here?
All right, well, this PCR from Gloversville, it actually says that the Gloversville Police Department had Narcan ready, and then I think the fire department pushed it.
Right. I believe the police department also had a say, we just didn't get any paperwork on it. They don't have, police department does not have any kind of first responder unit, but I believe they did report a save also.
So the police are sort of hit and miss in terms of whether they carry it or not.
No, I think they
all
Mike
carry it.
Mike would be able to tell us, but I think the police all carry it.
GPA carries it.
Different agencies.
So the issue of supplying police is no longer an issue, right? They just go out to the CVS and buy it.
Catholic Charities gives it to the.
Yes.
Gives it away. Yep.
We've had a couple of deaths. Do you have any deaths in your area?
Not that I was involved.
I mean, straight heroin, I don't even think it exists anymore.
Yeah, right.
You
You
know,
never know.
But we're finding that it is taking longer to wake these patients up in multiple
More
doses of
drugs.
Narcan.
And that's why the
get them.
the kits are now 4 milligram doses.
So there is, part of that, in those, you still have to perform some sort of airway support and ventilation to these patients, even while that Narcan is working. Like I said, it's taking longer and longer.
Does anybody
4
come upon-
milligrams, two separate doses?
That's what the pre-manufactured, they cost, I don't know, like $70 or something like that, the pre-manufactured kits that they're selling now, 4 milligram doses.
The
For
commercial-
intranasal, they're only like half an ml, so they're very well absorbed in those 2 doses.
I read a little literature about the Narcan, the heroin being cut with xylazine, and they said that is extremely resistant to Narcan, the xylazine, which is a veterinary tranquilizer. And they said that they're finding that very often they have to IV the patient and give a pain line, the Narcan maybe. And
All right. I think mankind's the only mammal that seeks to alter its consciousness.
Right.
Okay, so BLS, Gloversville, those are both interesting updates. Any CPAP observations, one way or the other? The save?
All good, no harms.
Okay.
I don't think it's used enough.
You think it's underutilized?
I think it's underutilized.
But they have it, but they just don't.
at the very end of our agenda here, I have some stats. I ran some stats yesterday on the state bridge about CPAP. Which
I-
are kind of interesting.
I agree, I preach it. We can save so many lives with CPAP.
So is there, I think it needs like a booster dose of education.
I think that would be beneficial, because it's certainly, people come in respiratory distress, and I've had like 2 patients that I've intubated that came in without it, and when they come in with it, they're good. I mean, before, I think initially when they started using it, at least in our facility, I'm sure other facilities, they get there, they take it off and just watch them and realize that they actually needed something for support. Now they're very good about switching right over to BiPAP. So that was educational for the hospital and the nurses, but I don't think it's used enough, at least not.
So they're coming in, they're dyspneic, but they're on a non-rebreather or something.
Yeah, they have a mask. Exactly. You find the same?
The data's incredible. If we start CPAP in the field, how many patients don't need to be intubated in the field or upon arrival at the hospital, as well as when it's used in the field, in the ER, how many of them don't have to go to the ICU after the fact?
And there was, I'm sure, introduction, there was a CPAP educational module, right?
Oh, yes.
Yes.
Yeah.
8 hours worth of it.
That was
Yes.
distributed.
Significant.
There was a lot of time in the demonstration project, and now we've got a fantastic PowerPoint by AAREMS.
Is there a way to study the underutilization? Joyce, is there a way to study underutilization, or, you know, they have it, but they didn't use it? Life squad.
I may have a little something on that, because in just a few minutes with my stats here.
Yeah, as far as the paper PCRs, I
Hard to
could look
tell.
at the, and you know, people with respiratory distress and see if, you know, see what I thought, but I don't know how.
We can ask all the county QA committees for their next meeting to make respiratory distress their focus for the month, and can all report back.
Phil, that's a good idea. Do you have it in your, if you pulled up in the state database, shortness of breath, can you look at implementation of
Oh,
CPAP?
absolutely. I already have, like I keep teasing you on here, I already have some stats on CPAP use, and it definitely is underutilized in the region. No question about that. As far as electronic PCR goes.
We're trying to use data. It's a little foreign to most medical circles. If we had the denominator of shortness of breath patients, and and then the numerator would be BLS,
Well,
CPAP,
I
or
can
any
run that.
CPAP,
I can run that, absolutely.
or other advanced airway would be the other.
Is where you're getting the information smart enough to be able to look at the same patient and say they weren't, CPAP was not used in the field, and then they got to the ER, they needed to be intubated?
Yeah,
Or placed on BiPAP.
I would have to,
The interesting thing, and my overall gestalt on the thing is that short of breath, they do the nebulizer, they'll do another nebulizer, and then they'll do nothing. They'll put the mask on, and then so that, but the patients haven't improved. And when they get there, the EMS people will say they're really not much better.
And how prevalent is CPAP? There's a lot of BLS agencies that now have it. Like, how replete is the region with
I've been looking at every paper PCR that I get, and I believe I mentioned the last REMAC meeting, I found one use of CPAP, and that was by an agency that was not approved.
they thought they were approved. They didn't realize it was a...
They didn't realize that they
Well,
had.
good for them. Let's get them approved.
I got a hold of them. They're very good. Well, I won't name them. A very good little BLS ambulance agency in the region, and they took the training. They just didn't know that they had to notify the REMAC that they had taken the training. And I said, here are the forms. I said to the captain, I said, here are the forms. Just fill them out and get them back to me. This was a couple months ago, and I haven't heard from them
We
since.
haven't heard from
So they know how to do it, but
They did it once quite successfully. In 2015, ALS CPAP use in the region, electronic PCR upload, shows 123 uses. And ALS CPAP use 2016 to date, 40 uses. BLS CPAP in the region 2015, as Joyce mentioned, once, and BLS CPAP in 2016 to date, 0. This is the electronic PCRs. And we have 9,095 electronic PCRs uploaded in 2016 to date. So out of 9,095, I do not know how many respiratory distress patients we had versus the CPAP use, but I can run that figure.
yeah.
So
So
let everybody know.
shortness of breath on the denominator, and then how many got something besides an oxygen.
Right.
Okay. Well, it sounds like, is there a general consensus that it's underutilized? Howard, you're going to say something.
I think part of the issue statewide, or at least regionally for right now, but statewide, is that it's not a mandated part of the EMT curriculum. It's an optional segment that can be taught. And although he'll kill me for saying this, perhaps this body could speak with Dr. Doynow about approaching it at the CMAC and maybe getting it changed statewide.
Putting it into the EMT curriculum.
It's hard to mandate because
It is.
you're legislated at a certain number of hours.
Right.
So whatever you put in, something else has to come out. Right?
Right, but now with the state ed standards, they can massage that a little bit better than they used to in the past. So I think if we find something that's simple and works, maybe it's worth fighting for.
At the national level, the national EMT curriculum, does it speak to it? Not really.
Not yet.
It's gonna be difficult anyway, even looking at the data to see how many of your difficulty breathings were anxiety, allergic reaction, asthma, that were fixed with something else and the patient
For
actually.
hypoxia. Right?
I mean, does each agency have a protocol where you do nebulizer first or two naps and then?
It's a state bill, protocol.
Okay.
CPAP is an option for those agencies that have it. It's not a medical control option, right? All right. I think, yeah, there's a lot of things that could go into the mix of like who we're actually talking about. But for starters, it'd be nice to know what the baseline is. And then we could say, if we think it's underutilized, the rate should go up. All right. Arkville, informational. They got blessed by the Department of Health, is that what it says?
Well, actually, neither blessed nor unblessed, if that's the right phrase. Their agency code has been archived due to a lack of active duty personnel. So,
So archive is a euphemism for deceased.
They are deceased. They're very upset, the few folks that are left, they're very upset that they could not have a reasonable number of personnel to man the agency, but they're working toward reinstating it sometime in the future, but right now they are archived. And if you'll notice, Cranesville, the next item there, Cranesville has resumed service as an BLS-FR agency with a new agency code. They were archived briefly for a month or so, I guess, and now they're back in business.
So, Joe, what makes them get archived? Disuse of like no runs, is that basically how you get archived?
I'm sorry, say it again.
How does this agency become archived?
Basically, when they can't, they don't comply with the requirements for BLS-FR. We give them 5 or 6 notifications if they don't respond to us, we archive it. But the only reason we archive it is to eliminate the number. We're not really eliminating the agency.
Right.
The whole purpose of the BLS-FR project that I'm in the middle of now is to try to determine get a fairly accurate understanding of actually how many BLS-FR agencies are out there. And we're beginning to find more and more, we're going, like, holy smokes, we really didn't know we were doing this. So, that's only as that makes sense. The whole purpose of the agency code is it's really a funding thing for education. It's not really you can do BLS-FR without an agency code if you want to get reimbursed for training. That's what this project is about, to identify how many, as accurate as we can, how many people are actually potentially involved in that. So it's a funding thing.
Okay.
So even if their agency code gets pulled, they can still go and respond to calls and everything else?
I'm sorry, say it again.
Even if their agency code gets pulled?
Oh, sure, they can go, yeah.
They still go respond to
It's got
calls?
nothing to do
It's not a
with
coercive
responding,
it's
it
just
has everything to do with whether or not they want to be reimbursed.
In the case of Arkville, I had a conversation with their former captain, who still wants to be a captain. They're not able to respond at all now, unfortunately. They just do not have the personnel wherewithal to do it.
They're actually trying to get a CF4 class together, which, if they do that, they can come back. Well, they don't even have to back there. They get a CFR class together, and they can start as the documentation, we'll give them the ways and take the
They're trying to work in that direction, yeah.
So the incentive for Cranesville to get a new agency code and resume
Yeah,
is
it was just, really that's an internal for us, so we can identify what they're
Yeah, they already have a new agency code, guys.
They
They're back,
don't need an agency.
back in the list.
Yeah, but they want one because there's
They want,
incentives.
they want to be able to reimburse the training.
Right, okay.
Joe, how long do you go into respond?
I'm sorry?
How long do you go into respond?
I give them 6 months. It really, it's just a continuing process. They don't respond in 6 months, it's like, are you okay?
So Joe, you issued all those letters, what's the drop dead date?
I'm sorry?
Question, what's the date that, you issued all those letters last fall,
Yeah.
so if they haven't replied by now, are they all just getting cut off is the question?
No, we give them 30-day increments. So if you don't respond in 6 months, it's 30-day increments, so you're just not interested, so we drop you. Be surprised how many times people say, oh my God, when they get my letter saying, hey, you don't have an agency code anymore. That's what happened with Brandon. They said, what do you mean we don't have it? And I sent them the 6 letters. They said, well, I never got that. We don't have accurate information. That's why we're asking you for information.
Wrong mailbox.
Yeah, so it's a, you know, it's a secondary project in the office, but it has to be done.
Joe, you know, from an educational standpoint, when these guys are coming into class and they're filling out their voucher paperwork, many times we look up on the website to see if their agency has a code.
You
And
probably
if
don't
that
make
website isn't updated,
That's why we're trying to update the code.
okay.
Okay, and there are, a lot more of it is the CME program. They'll start sending paperwork into the CME program.
Oh, boy.
And Gene Myers will go, who are these people we don't know? So they think they have, you know, they have an agency code number, but they haven't updated it in so long.
Okay.
That's the whole purpose of the agency code is funding for training, nothing else.
The BLS FR agencies in our region are, I find them notoriously slow to communicate their email addresses. Every once in a while, a member of one of their agencies will call up and say, how come I'm not on the mailing list? And I'll say, because your agency has never told me what your email address is. Oh, you know. So, but most of our BLS first responder agencies do not have an accurate email address, and therefore I'm not able to contact them.
How does that affect a course sponsor? So when the student fills out an application and says that they're with an agency, does it affect the course sponsor? I mean, we charge tuition, so it doesn't matter for us. It matters for them when they go to reimburse,
Right, that's what.
get reimbursement. But as a course sponsor, does that affect you, or do you still get reimbursed?
They're not with the New York State Department of Health agency.
So you don't get reimbursed. You don't know that unless you check every single application.
No, we'll know that when a course memorandum comes out, and it's
Wow.
checked, that they are eligible for funding.
All right, next up, Mr. Farrell's going to brief us on updates on agency compliance.
As of right now, just everybody in this region is compliant. This go around.
Arkville is the only one that's been archived as of the last 3
Yeah,
years.
that's a couple more that they have.
All right, and then some, Phil, you're going to do some regional statistics.
Yeah, I have some very fascinating regional statistics. I have a handout here today, up front here, with some regional statistics, and then I have a kind of an extrapolation on that I wanted the REMAC meeting to be aware of. But we currently have 27 agencies in the region out of a total of 66 that are approved for electronic PCR use, and of them, 22 are reporting actively. There are 5 that are not actively reporting at this time. In other words, they're approved for ePCR use, but they haven't started the use of ePCRs yet. A total paper PCR screen last year in our region was 15,604. Total ePCRs uploaded in our region last year was 28,254, which means that 65% of all PCRs generated in our region in 2015 were electronic. Total paper PCR screened in AAREMS for 2016 to date, as of yesterday, was 3,061. That's the paper PCRs. Total electronic PCRs uploaded to date this year, 9,095. Now, with that figure of 9,095 in mind, I'll back up a year. Chest pain, primary symptoms. This is fascinating, and I would like to pursue this a little tighter and find out some more details. Chest pain given as primary symptom last year, 1,342 times. Oxygen given when chest pain was the primary symptom last year, 187 times, 14%. Chest pain as a primary symptom, 2016 to date, 403 reports. Oxygen given to date when chest pain was the primary symptom, 63, for a total of 16% of the time. Now there can be, as I think Tony mentioned before, there can be mitigating factors. We don't know exactly how that followed through about the chest pain, but on the face of it, it is an interesting statistic that oxygen is not being given very often when chest pain is given as a primary symptom. Aspirin given for chest pain when it's a primary symptom, 358 times last year. This is out of 1,342 patients that presented with chest pain as a primary symptom. Excuse me, aspirin given for chest pain primary symptoms last year, 358. That was 9 agencies. Only 9 agencies out of 22 reporting. Aspirin given for chest pain primary symptom this year to date, 381. And that was for 5 agencies, only 5 agencies.
What was the percentage? Excuse me, percentage on the aspirin compared to the oxygen?
I'm sorry, Tony?
What was the percentage on how many patients? You said it was 14% and 16% for oxygen?
For oxygen. I didn't run the percentage on aspirin, I'm sorry.
It's
I'm
more.
sorry.
It's more aspirin than oxygen.
I would hope so, since that's what the protocol asks you to do. Aspirin is part of the protocol for chest pain. Oxygen is not, unless the O2 sats are below 94%.
Right.
So,
I find myself with our own squad, and I have to keep reminding folks, if they get an oximetry reading of 94, and the patient is presenting with cardiac symptoms, they say, okay, I don't have to worry about oxygen. And I tell them, please, worry about oxygen if it's 94%, and the patient is presenting with cardiac symptoms. But in any event, adult IO in 2015, intraosseous 119 reports from 12 agencies. Adult IO in 2016 to date, 40 cases from 8 agencies. Narcan intranasal last year, 15 times from 4 agencies, all ALS. Narcan intranasal this year to date, 3 times from 3 agencies, all ALS. Controlled subs total last year, 1,948, 15 agencies reporting those. Controlled substance this year to date, 628, 12 agencies reporting, and this is out of 22, the total agencies reporting electronically. MS given last year total 1,252 times by 13 agencies. MS given this year total 266 times by 8 agencies. IV MS is given approximately 8 times as often as intramuscular. Fentanyl last year 863 times reporting from 10 agencies. Fentanyl this year to date 216 times, 8 agencies reporting. So a lot of agencies with controlled substance licenses are not using those licenses, if you will, for whatever reason. ALS CPAP use last year, 123. ALS CPAP use this year to date, 40. And I mentioned BLS CPAP use last year once. BLS CPAP use this year to date, 0. So those are some statistics. I'll run that, Tony, I'll run that percentage for you when I get a minute and announce it.
Find out a difference in the Narcan, is reported whether the Narcan was given before EMS arrived?
Yeah, that I did not, that I didn't look at. And I'm not entirely sure there's a data point that can record, and I don't know, I'll have to look it up. I'm not entirely sure there's a data point whether it shows medication given before arrival or not. I'm just not sure.
So just, I'm thinking outside the box, because every software company is different, and obviously it requires some backdoor stuff unless you're using, I don't know, the software that the state bridge, but the Narcan numbers are way off, I can tell you right now. So I would be curious to know what agencies are reporting. As a head of an agency, I want to know if our agency is reporting, because I can tell you that we have given Narcan 3 times in a 24-hour period, let alone our Narcan uses are way up for 2016. So that tells me that there's an error in reporting, and that very well can happen with NEMSIS categories and how they upload. So That data just, it doesn't seem accurate.
Even the controlled substances don't
Controlled
seem-
substances, I mean, right, it's way off. I mean,
Yeah.
we have pushed more fentanyl on a quarterly basis than what's reporting there. So, as an agency head, I wonder if my software is talking to the state bridge correctly.
Okay. Tom, I will be very, I'll do this for any agency that requests it. I'll be very happy to zero in on GAVAC and tell you how many were reported. Absolutely, sure.
Is this pre-hospital and in a facility, and maybe that's where the discrepancy is?
This is as reported on the electronic PCR.
So that's all comers.
Mhm.
I mean, I find it hard to believe we're in May, and there's only been 3 reported uses of Narcan by 22 agencies, when I know that we use it 5 times a week.
No, that was 3 intranasal uses in there, Justin, correct? Phil, the uses of Narcan, was it intranasal or was it any use of Narcan?
No, this is intranasal. Yeah, this is just intranasal. I can do it any number of ways. This is what was reported intranasal. I can tell you total number reported. I can go at agency by agency and let you know about our own particular agency what's being reported.
Tritex, E-fusion.
What is everybody, who else does these PCRs?
We're using image trend. Bill, what's rural metro use?
Zoll currently, but it's changing.
We're using Red Alert.
So they're all kind of different. So
I use EMS charts.
So my guess is that Image Trend is probably reporting correctly to Image Trend.
No,
It-
because I'm Image Trend, and I know we've given more.
Then 22?
Yeah.
So again, I don't know if that's a state thing on their programming end, and it's great to have data, but it's got to be accurate.
Maybe someone should ask Mike Taylor if he wants to come to one of these meetings and you could give him an earful. I mean, share your concerns.
I had a long chat with Mike yesterday and gave him an earful then, and my impression, Mike was very patient and deep sighs punctuated the conversation on his part. He's being given an earful by a lot of folks around the state about electronic reporting. I get the impression that there still has to be some tweaking done on the...
There's one of the software programs that's having all types of issues internally. It's the software itself.
There are 2 agencies in our region, I will not name them, there are 2 agencies in our region, one of which has been uploading since last June and one since March of 2015, and nobody can find the data that they uploaded. Nobody can find it, including their own software representative. It's a drifting cloud, you're right. God only knows where it is, and Mike doesn't know, I don't know, and we're both looking very avidly, and he's able to look a little bit more efficiently than I am, because I can only look within AAREMS, he looks for the whole state. But there's, in one case, there's 135 PCRs, PCR data products out there, if you will, from this one agency. He claims he's been uploading them, and we just don't know how they got uploaded and where they are. They're someplace in the cloud, unquote. I'll tell everybody when we find them. Mike is confident we're going to find them. It's just going to take a while.
So Phil, the database on the state end, that is the state database now, right?
Oh, yes, yeah.
There's no other backyard key punching going on, right?
Well, there is still key punching for paper agencies.
Okay.
But they're behind on that because there was no contract for, how long, Phil? A year, 2 years? It was more than 2 years.
Almost 2 years, yeah.
So I
Going on
think
3,
that
actually going on
feature's
3
gonna
years.
be
Going on 3 years. It was.
electronic. I think, that for the data to be useful or actionable, it has to be trusted.
Right.
And it sounds like there's a gap between what the agencies know is going on. So if you did even a side-by-side with GAVAC and Rural Metro and some of the larger agencies that are EPCR, compare it with what the state has, say, for this year, that'd be an audit worth doing, I would think.
The problem with the state bridge is you're getting, let's take Amsterdam Fire and GAVAC. We both report it, we both document it. on our PCRs, now you have double reporting right off the bat.
Same patient. different
Same patient,
PCRs.
but you've got double the use of Narcan, double the use of oxygen, double the use of any of those.
That would lend itself to over-reporting.
Oh, no doubt.
What we're seeing is under-reporting, so
Right.
it's, it
So
could be
it's
all.
gotta be a
of the above.
programming.
But doesn't that bring up a different question, and we ran into this in Schoharie when we have two ALS agencies there. Should we be reporting what another agency is doing, even though they're working on the same patient? Or not?
Patient care report.
On the PCR, and what Joe, the answer was no, we shouldn't. So if another agency is giving the epi, and we're doing the airway, their PCR shows the epi, ours doesn't. Ours shows the airway.
That makes all the sense for State Bridge. What about the
But it
doctor
all
at the
should be in the
hospital
narrative.
for unique-
I'm gonna punch it.
I can tell you that, I mean, when we run paramedics on a truck with other paramedics, it's documented, the medications that are given, as far as I'm concerned, we are equally responsible.
I'm not arguing, Tom. I agree with you. This is what I've been told, this is why we asked the state, and that's what DOH told us.
Yeah, you can see where it's gonna go. It's gonna, you're gonna wristband the barcode to the patient, and then you're gonna scan the patient. And it doesn't matter what agency you
At the
Yeah.
bedside.
Yeah, as we're sitting there in the.
And the other side is, you don't have to have both agencies checking the box epi on the PCR, but you can still write a narrative, epi given by,
Right.
and then, so you're still covered by the doctor in the ER when he reads, okay, epi was given,
Right.
and you're still
That's
getting
what we're
reported.
doing now is, in the narrative, we're saying ACLS protocols or regional protocols for this followed by da-da-da, refer to their PCR for further documentation.
So the way we trained and built our system to be able to check boxes, and now guys are gonna write a 3-page novel of a narrative.
Well, I
We
mean,
don't put that, we do the, if Gavac does something, it's marked that Gavac did.
right.
And I'm sure on their end,
The
it's.
crew member, you still add the procedure, or you add the medication, and then you just select up the crew
Given by other
member
person.
that would have given it. So we would select if AFD gave it, and we would select the AFD medic gave epinephrine. But it's still in that list of medications given to the patient.
Right.
But it's documented as being given by somebody else.
Correct.
Because otherwise you'd have two incomplete pictures.
Right, Phil, does the State Bridge show the, whatever typed commentary or written commentary is also on the PCR?
I was just about to mention that, Gus. I found out something very interesting in one of my conversations this past month with Mike Taylor. I asked him, I said, now what techniques do I have to use to navigate down into an actual PCR and take a look at it? He says, you can't do it, and neither can the state. The attorneys for the Department of Health, at the beginning of the State Bridge, several years ago, it's only about 3 years, at the beginning of the State Bridge, you could actually, in your region, you could actually go in and get chest pain, such and such a date, such and such an agency, such and such a PCR, who was on the run, what the narrative, and so forth. And the state attorneys finally decided that this was a violation of HIPAA, and now nobody can look at the individual PCR except the agency, the region, has a right to ask the agency for a copy of it from their own files. But that's something that the agencies agree to when they agree to go, when they seek approval to go electronic. But right now, I cannot go into the State Bridge and actually open up an individual electronic PCR. And neither can the state of New York. They can't either.
So you can't track procedures by EMT?
No, I can do that only by contacting the agency captain or the agency contact officer and saying, I'd like a copy of all the PCRs that John Jones handled in the last month.
So where does the HIPAA
by
come in with the
by
paper
regulation, you
PCRs
can-
you're getting?
I'm sorry?
On a paper PCR, you can see that information and that's okay?
I'm just telling you what the
Yeah.
state lawyers have decided. No, I didn't
You should be a
decide.
lawyer.
I didn't decide, neither did Mike Taylor. He
Well, yes
found
and no, when it
first
gets key punched, that key punch information isn't in there. It's only certain fields in
But
that
still,
PCR that
our
are key
regional
punched.
director can see that. The regional director can't see our electronic PCR.
They can if they request it.
If
I-
they
I-
request it.
Yeah, I have to request it from the agency.
But we have to give them our
The
paper
agency, not the
PCRs.
state.
Yeah, you
Those of
have,
us that-
if I request the electronic PCR, you're supposed to give it to me too, but, and I'm sure you would, Jill, I'm not arguing.
Oh, yes, I would.
There's probably that more than one person other than just Phil could go in, anyone from DOH could go in and see all the patient information.
So the attorneys have decided that nobody, even the state, can go into the state.
If there was a way they were telling him that he could do it, I'm sure somebody else could figure it out. It was a little more computer savvy, no offense.
Believe me, not taking it.
So the comments on a PCR are really not part of the database?
Correct. Lou just asked me, could I break it down demographically by age and sex and so forth? And yes, I can do that, but I can't actually open up the actual electronic data, the electronic
Yeah,
patient care.
the first swipe would just be to look at, some of the bigger PCR agencies and just count how many PCRs they have and see if it close. All right, well, work in progress.
Work in progress. Every turn of the wheel brings it a little tighter, a little tighter. Now, Mike Taylor keeps telling me that when the new version 6 of the paper PCRs come out, they're going to be NEMSIS compliant. In other words, they're going to be several pages long, and they're going to be all little checkoff boxes. And they're apparently scannable, so they can be scanned electronically at the key punch center. Can't wait.
So, okay, thanks. There was a document that got emailed, I think, to everybody, which was new guidelines for course sponsors. It had a whole new section to it, and Howard was asked, Howard, is this going to be, workable, livable guidelines for course sponsors? Where does that come from? It has our letterhead on it, but is it coming from the state, or is it coming from from REMO, or?
You mean the new CIC requirement?
Yeah.
Yeah.
I think the policies and procedures you're talking about. Yeah, no, that's ours.
Oh, okay, yeah.
So we created that.
We created that.
Okay, so
But that's for the AAREMS training center.
Right.
Right.
Not for, it doesn't,
That
every
only
training
applies-
center has their own policies and procedures manual. AAREMS is a core sponsor, so that is just the AAREMS policies and procedures.
The occasion for updating our policies and procedures is the fact that we have to renew our course sponsor certification by next month. So that's why Joyce put
Right,
these together.
and I put a little note in there specifically for Howard, because Howard's right now working as our course coordinator for the instructor courses, as to whether if he thought any of this was going to come back to bite us, and but that's our own policies and procedures that have to be sent in with the renewal of the course sponsorship.
Okay, so it's something AAREMS as a sponsor did on its
Yes,
own.
we've had course policies and procedures for years. This is just an update.
But there's no such thing as a regional similar policy procedure.
Not for all core sponsors in a region, no.
No,
Every
no,
core
they each
sponsor
have
has
their
to have
own.
their own policies and procedures.
Yeah.
Okay.
This state has standards that have to be met, but
Right.
it's up to each course sponsorship to how they incorporate those.
These are sort of unique because we are the ones that sponsor the instructor courses. So they're a little bit different than what a regular course sponsor would have.
All right. Any other business for the REMAC?
I don't have anything, Gus, and we do not have any information that necessitates an executive session this month.
All right, recess.
One more thing,
Wow.
can the REMAC issue an advisory encouraging CPAP use and revisiting education as well as the QA/QI to all agencies?
Yeah, we did say we were going to do that. And now's the time to bring it up. Thank you. So, Joyce, education, region-wide, relative to CPAP. We can do the data, well, now we don't trust the data, so we don't really care anymore. But just a general educational, maybe like a one-page synopsis of the 8-hour course that says, these are the kinds of patients who may benefit from CPAP, and
Okay.
there's a general sense that it's being underutilized, so if you have it and the patient meets criteria, please deploy.
Please use it.
Was there another part to it, Dave?
Shipping out an advisory from the REMAC as well as the QA/QI as Deb recommended.
And what did we assign as a QA/QI? Just to
Short breath audits.
Oh, to the.
to determine appropriateness
Now,
of,
this is, I was.
CPAP.
Oh, at county level.
What is, what is?
All right, any other business?
Have we done, has the REMAC done everything that they need to in order to be ready when the collaborative protocols go to CMAC next week? Is there anything that needs to be done?
I don't think so. We had a chance to review it.
Okay.
So when the state council approves them, you don't have a REMAC meeting next month.
Yeah, but they don't take effect till when?
You decide here when they take effect
Right.
and how they roll out.
is there
So
any?
so they're slated for CMAC next week, the collaborative protocols. I can't imagine that they're not going to be approved. So I guess the big question is, when does this region want to implement those changes?
I'm going to be talking to Tim Marabli at Remo. I'll probably talk to him before they get it formally approved by CMAC, but we're going to be visiting about getting the app updated. And he's got the contacts with the app. That's out in California, the folks who developed the Android app. And
Are they developing some kind of training program, or what are they going to do for training?
that I don't know.
What's the rollout,
Yeah, what's the necessary requirements to roll out the new?
the educational portion?
That I don't know either. I suspect every region can set its own. I suspect.
I say we copy somebody's.
I'll have to copy.
I'm sure it's done in remote.
I agree.
That's what Remo said.
Copy the educational piece.
I think there has to be some sort of a rollout. We can't just say good luck with that.
Yeah.
Right.
Go with that.
So should there be an interval of time between passage at CMAC, assuming that it's successful?
So the last time I think that they were approved, the rollout date was like January 1 or something. That cutoff.
I think it's gonna depend on what the rollout process is. I don't know that we can say when it's gonna happen until we know what the rollout process is.
If I remember correctly, Dr. Daly put together a training session on the new protocols last time.
Right.
I wouldn't be at all surprised.
I'm sure he'll do the same thing.
Yes, and that is still posted on our website. I can just replace it with the new one when that comes up.
And then do we have any sort of means to document that every provider does it, or we do it at agency levels? How do we know that everybody has gone through the rollout process so that the protocols can then be?
My suggestion would be, given our current state of development, it's better to do it at the agency level. That's the way we're doing the
And
test.
then have every agency let the region know that every
But they're-
provider is on?
Just like they let us know that they're keeping up to date with their yearly skill sets and what have you.
There was a deadline date the last time for all the agencies to.
I don't remember.
Yes, there was.
February 15th or something in February.
It was a January 1 rollout and a February 15th have them in place for the 2012. The 2015 updates was very fluid and very lax.
Right. There's some significant changes in
Oh,
these
there are.
protocols, so I think
There are
a
some things
formal
that need-
rollout with documentation of education provided is necessary, and I don't think that we should go online with it until every agency has demonstrated that every provider, ALS and BLS, because it's ALS and BLS, it has
I
been
think we
appropriately.
can do this very efficiently, the rollout I'm talking, on the agency level.
Yes,
I think we can.
so we just have to figure out what the rollout is,
Right.
and then set a date, and then tell all the agencies to do it. And then whoever's not, whichever agency hasn't come up to 100% compliance, can't practice on the new protocols. I guess, right?
That's so hard for the doctors, though.
The doctors don't know the difference. Okay. I'm sorry.
So the agencies that don't have 100% compliance are gonna use the old protocols?
I don't think that that's a good option, but what are we gonna do, right? People can't use the new protocols until they've been trained in them.
So Remo really doesn't know either. Dr. Daly's saying that they will most likely roll out at some point in the fall. And I just asked.
His underlings haven't prepared the training yet.
Right, and that's why I just asked, will you be creating an educational piece?
I'll be talking to Tim within the week. I will be talking to Tim because I want to talk to him about updating the app and then we'll talk about the rollout and so forth.
So
Without
it sounds
actually
like this
putting-
isn't gonna happen before we meet again.
Oh, no, I'm sure it's not.
Yeah.
Without actually printing the books, the app thing would be interesting, to see how long it's gonna take to
Yeah.
update that.
Take reciprocity from other regions such as Remo. and-
Well, the agency has to see evidence of that, and each, I mean, from our perspective, I think each agency says, yes, all our people are trained. However they got trained is
That's what we did the last
figured out.
And that's what he said. He said all regions are gonna participate in this educational, creating the educational piece. So
So-
my guess is each agency, or each region will be tasked with certain protocols that they have to tackle.
So everybody needs to understand that once these protocols are approved, they're not in place until training has been done and you've been authorized to use them.
For what it's worth, I'll make sure every agency understands that completely, and they have the information before them.
Because since everything is publicly available, as soon as those protocols are approved, someone's gonna be looking to use them.
Every day we can get the regional protocol